Hi, everyone. Welcome to the Lymphoma Research Foundation's Ask the Doctor About Lymphoma program. My name's Hope Avalone, and I'm the Senior Program Manager of Patient Education here at the Lymphoma Research Foundation. We'll get started on the program very shortly. I'll just give everyone a moment to log on and to get situated. But while we wait, I do want to go over a few features of today's program. So first of all, everyone is muted automatically upon entering the program, and that's to reduce feedback and other sounds while the speaker is presenting. Also, I wanted to review the buttons at the bottom of your screen that you'll be using today. Please use the first button, the chat function, to ask about any tech issues that you might come across today. But if you do have a question you'd like to ask to our speaker, please do submit those using the Q&A box, which will be the third button at the bottom of your screen. You'll have the option to make any questions you submit there anonymous. And at the end of the presentation, we'll aim to address as many questions as we can before the conclusion of the program. But after the program, we do encourage anyone who might still be looking for more information about their lymphoma to reach out to LRF's helpline at 800-500-9976. And you can also reach out via email at helpline@lymphoma.org. But for now, let's get started on today's program. So thank you again to each of you for joining us on today's Ask the Doctor About Lymphoma program on navigating an ultra-rare lymphoma diagnosis. We know that access to expert disease information is so important, and so we're thrilled to be able to bring you this educational program today, especially on this year's Rare Disease Day. At the Lymphoma Research Foundation, our mission is to eradicate lymphoma and to serve those touched by the disease. LRF is the nation's largest nonprofit organization devoted to funding lymphoma research, as well as providing patient care and comprehensive lymphoma education for patients and healthcare professionals alike. And that's all using input from our scientific advisory board. And in addition to our patient education programming, LRF focuses on our research portfolio to help fund the future of lymphoma care. LRF also offers a variety of educational resources and support. So in addition to our live educational programs like this one, we also have subtype and treatment specific fact sheets and guidebooks, as well as a mobile app called Focus on Lymphoma. And for this group, I specifically wanted to highlight our clinical trials information service, which provides patients with information about investigative treatments for lymphoma being evaluated at cancer centers nationwide. So upon requests, LRF's helpline staff can conduct a search for potential lymphoma clinical trials for which you may be eligible. To find more information on any of these resources, including the Clinical Trials Information Service, please reach out to our helpline at 800-500-9976. And again, the email for the helpline is helpline@lymphoma.org. Also wanted to briefly highlight our upcoming lymphoma workshops. Lymphoma workshops are one-day educational programs that provide the latest information about lymphoma, current treatment options, and patient support issues. Our workshops include subtype-specific breakout sessions where you can hear about your specific type of lymphoma from an expert. So the National Lymphoma Workshop will be held virtually on Saturday, March 16th. If you're in the Midwest region, or if you will be traveling to the Midwest region, our Midwest Lymphoma Workshop is in person and will be held in Chicago on Saturday, April 6th, and you can view the agenda for either of these programs at lymphoma.org/lymphoma workshops. This program is made possible by grants from our sponsors, and we greatly appreciate their support of our Ask the Doctor programming. Finally, I am honored to introduce our speaker today, Dr. Pierluigi Porcu. Dr. Porcu is a physician scientist focused on NK T-cell lymphomas and EBV-associated lymphomas at Jefferson Health, where he's also the director of the Division of Hematologic Malignancies. Dr. Porcu is also a professor at Sidney Kimmel Medical College under Thomas Jefferson University, and we're so pleased to have him on our program today. So without further ado, Dr. Porcu, I'll now turn the talk over to you.
Thank you very much, Hope. Very happy to be here. And I see there's a very strong participation here. It looks like we have 110 people already on Zoom. I'm sure there would be more as we go on. And I'm going to start sharing my screen. Here we go. Okay. Hope, tell me if everything is looking good on your end.
Looks good.
Okay, terrific. All right, let's get into it. So today, the task is I would say complex but fun as well, because we are going to have an overview of rare and ultra rare lymphomas, and the four ones that we have sort of primarily sort of identified are listed here. So T-cell and NK cell lymphomas, EBV positive lymphomas, post-transplant lymphomas or lymphoproliferative disorders, and primary CNS lymphomas. I think that what I want to make sure the audience is comfortable with is the fact that, first of all, each one of these topics is huge. We could be spending 2 hours just discussing any given one of them. And at the same time, it is not comprehensive. So there may be, type of rare or ultra rare lymphomas that are not listed here. So within my ability to address questions related to topics in rare lymphomas that are outside of the four listed here, I would be very happy to give it my best shot. And take any questions that anybody in the audience has. So if for some reason what I'm saying today, you find out it doesn't necessarily apply specifically to you, I don't want you to be disappointed, and I want you to stay on and make sure that you put your questions in the chat, and I will make sure to address the questions. So what is it that we're going to discuss? I mean, of course, a lot about, how rare and ultra rare lymphomas are diagnosed, something about their clinical presentation and therapy. Of course, I'm not going to be able to cover a lot of ground specifically on each type. Something about clinical trials, which is very important because that's how we're making progress, particularly with rare lymphomas and the challenges of rare lymphomas and clinical trials. And then the issue of, something that Hope, I'm sure, is going to then address as well, finding an expert, tips to manage quality of life concerns, and then Q&A, and then the lymphoma LRF resources that Hope has actually already just showed to you. I always like to start with some couple of very basic slides, which I hope that they're not too simplistic, but I think I always prefer to start from ground zero. And what the kind of malignancies that we're talking about today, they're all blood cancers, of course. And the reason why they're called blood cancers is because they derive from cells that are originating into the bone marrow. And the bone marrow is the primary source of all the blood cells, no matter where they are. Blood cells grow in the bone marrow, they develop, they mature, and eventually they go to the periphery, sometimes in the lymph nodes, sometimes in blood, and then often they come back to the bone marrow. And these cells are sort of shown graphically depicted on the right in that cartoon. And of course, this includes red cells, white cells, platelets as well. When we're talking about lymphomas and leukemias, in particular, we're looking at cancers that derive from lymphocytes. And those are the cells framed into that red square. And so we have B-cell lymphomas, T-cell lymphomas, and NK cell lymphomas. Now, a very basic slide, but let's go through this. So what's the difference between lymphoma and leukemia and myeloma? It may sound sort of obvious, but actually it is not. because you think about leukemia as a cancer of blood cells that develops primarily in the bone marrow and manifests itself primarily in the blood and the bone marrow. But as anybody who has leukemia knows, leukemia can be pretty solid, as Clara Bloomfield used to say. And therefore, leukemia can go into the lymph nodes, can go into the spleen, can go anywhere. But leukemia, the definition is a disease that really primarily develops and affects the bone marrow. There are about almost 60,000 cases each year in the US. Lymphomas are cancers of the blood cells that develop in the lymph nodes. So the blood cells originally develop in the bone marrow, but then they mature, they go into the lymph nodes, and that's where the cancer develops. And that's why people with lymphoma primarily have, an enlargement of lymphatic tissue, so lymph nodes, spleen. But anybody with lymphoma can also develop disease in the bone marrow and the blood. And lymphomas are more common than leukemias. There are about 89 to 80,000 cases each year in the United States. Finally, myeloma is a particular type of cancer of the blood that derives from plasma cells. Plasma cells are a very terminally differentiated type of blood cell, develop in the bone marrow. They manifest itself primarily in the bone marrow and the bones themselves, and cause particular damage to the bones. And there are about 37,000 cases each year in the US. So this breakdown then lead us to the question, what is a rare disease or rare cancer? And there's no single definition. There's an office at the NIH, that is the Office of Rare Diseases Research. The office was really developed initially primarily to study rare pediatric genetic disorders. And that's still the primary sort of effort of that office, but they're also interested in supporting research in rare cancers as well. So what is the definition of a rare disease, of a rare cancer? There are multiple different definitions. The one that I think are the closest one, or the ones that people that use the most, are the ones framed in the red box. So if you look at a certain number per 100,000 people per year, is anywhere between 6 and 15 per 100,000. And if you look at absolute numbers, so how many overall, diseases and cancer that affect 10,000 people or less than 5,000 people per year. Now, we all learned just a few days ago about, a terrible example of, and sad, of somebody who passed away of ultra rare cancer. It was not a lymphoma, but Gary Sinise's son, Mac, who just passed away a few weeks ago from this ultra rare cancer of the spinal cord, chordoma. So this is just a very recent example of something tragic that happened, and the fact that these ultra rare cancers really affect a lot of people. And this is shown by the American Cancer Society, that essentially established that 1 in 5 cancer diagnosed in the US is a rare cancer, not necessarily ultra rare, but rare. The rare is defined as an incidence fewer than 6 cases per 100,000. So one of those definitions I have on the table. If you look at all of this definition, 200 forms of rare cancer compose around 20 to 25% of all cancer diagnoses in the US. So, individually, and this is always what I say to people who have, with T-cell lymphoma in particular, which is a lot of what I do, that, T-cell lymphoma, sure, they're rare, but if you put them all together, they actually are affecting a significant number of patients. So very important to keep track of these numbers, and also to make sure that you know that you're not alone, when you're diagnosed with one of these rare cancers. So how do we kind of break down then, the leukemia, lymphoma, and myeloma in the US? This is just kind of a summary slide from the American Cancer Society, showing that between lymphoma, myeloma, and leukemia, there are about 185,000 cases in 2023. You have to understand that when we look at blood cancers in general, and we look at large sort of health, public health decision-making, or big statistics at the level of the NCI, or at the level of Congress, they consider blood cancers in general as rare disorders. For example, I often find funny that myeloma is considered a rare cancer. So there's a battle that we have to, there's a fight that we have to fight, and I think there's the continuous education of policymakers and regulators about the importance of these rare cancers is very, very important. All right, so going deep, diving now into lymphomas. There, as you know, probably there are a couple of ways of looking at lymphomas and classifying lymphomas. One is, I call it simple, and that's shown on the top on the left. Hodgkin's versus non-Hodgkin's. By those criteria, Hodgkin's clearly is a rare cancer, even though we don't often talk about Hodgkin's as a rare cancer. But certainly with 8,000 cases per year, it's just a minority of all the lymphomas that there are. Now, if we look at this cell of origin, the lineage of this and the cell type of the lymphomas, you will see that most of them are B-cell lymphomas in blue, and T-cell lymphomas are just a minority in red. And then there's a very, very small minority, less than 1,000 cases per year of NK cell lymphomas. So in this situation, NK cell lymphomas will be considered ultra rare, and T-cell lymphomas in aggregate, they will be considered rare. Now, there's also a more complex ways of classifying lymphomas, which is shown in just an example of the blue, we call it the blue book, which is a WHO classification. This is the one from 2016. Just recently, in 2022, the WHO released a new classification that will be the fifth revision of the classification, and another organization sort of separately from the WHO is called ICC, the International Consensus Classification, released their own classification of lymphoma. There are a lot of similarities and some distinctions, and altogether there are more than 80 different types of lymphomas in both classification, and some of it is shown in the pie chart on the right. And you will see that if you take individually each one of those lymphomas, there, many lymphomas are, very familiar, certainly to this audience, very familiar to oncologists. Then with the exception of diffuse large B-cell lymphoma, which makes about 30% of all the non-Hodgkin's, and follicular lymphoma, which makes about 20 to 25%, all the other really a rare lymphoma. So if you have Malt lymphoma, that's a rare lymphoma. If you have mantle cell lymphoma, it's a rare lymphoma. Burkitt, it's a rare lymphoma. So most of the lymphomas are rare diseases. And this is shown here. If you look, and this is just a partial list, but if you look at this list with the B-cell lymphomas on the left and the T-cell lymphomas on the right, and all these are the ones that are listed by the, with the red arrow. All those are rare or ultra, I would say ultra rare lymphomas. Anything that has, that makes less than 2% of the lymphomas is, I would say, an ultra rare. There are some of them, and that they don't have to be T-cell. There's also plenty of B-cell lymphomas that are ultra rare. Certainly, the splenic marginal zone, the Waldenstrom is considered an ultra rare lymphoma as well. Burkitt. There are perhaps more on the T-cell side, and all of them that are shown here that have less than 1%, they will be considered ultra rare. Are we going to be able to talk about all of these lymphomas? No. But again, please put your questions in the chat, and we'll make sure to address and discuss any question that you may have. So I want to spin this even a little more. So we said that diffuse large B-cell lymphoma is the most common type of lymphoma, makes about 30%. Sure. But if, there are so many different types of diffuse large B-cell lymphoma, if you break it down, each one of these different subtypes is either a rare or an ultra rare cancer, and you can see them listed in with a red font here. Primary CNS, it's ultra rare. Primary cutaneous DLBCL, leg type, ultra rare. Each one of these lymphomas, there are probably fewer than 1,000 cases a year in the United States every year. That was for diffuse large B-cell lymphoma. This is just kind of a composite big picture view of all the different types of T-cell lymphomas. They're kind of, hard to remember, and certainly we're not going to go through all of this. But just to give you a big picture view of how many different types of T-cell, NK cell lymphomas there are. All right, so just a few early take-home points here. One, mostly blood cancers are relatively rare, as I mentioned, 5,000, 8,000 cases a year. Many are quite rare, 2,500 to 5,000 cases a year, and some are very rare. So what's the challenge here with this? And you are familiar with this just as much as I am. Is the fact that investment in research and development of new drug is challenging because companies naturally they work in their planning looking at market size, and so even though there has been a lot of movement in rare cancers, I would say in great part because of the advocacy that has gone to address that unmet need. But there has been movement, and a lot of new drugs have been developed that are specifically targeting rare cancers, even ultra-rare cancers. The challenge, and that's a challenge from the standpoint of the model for drug development, and then from the standpoint of the regulatory agencies like the FDA, how do making sure that the path is and the process is good. Clinical trial accrual for these diseases can take 5, 6, 8 years to recruit a number of patients that in breast cancer, for example, you would take 2 years to recruit. So that makes it a process slow, and of course it's a big issue. The other is that the development of disease models in the laboratory is much more complex. There are fewer tumor samples, and without tumor samples, it's impossible to develop models. And very often they are not good. Even the models that are available, they're not great. So that's another reason why research has been slow on this. Now, again, to make sure that this is you're aware of positive development, there is a lot of good development in translational research in rare diseases, not just lymphomas, but outside lymphomas as well. It just requires coordination. It requires collaboration across all the different components of the research spectrum. So these are the 4 lymphomas we're going to discuss today, and I decided to show them with these sort of overlapping circles because it just happens that there is overlap, and the main area of overlap, interestingly enough, is EBV. Which I'm sure is not a coincidence that the LRF sells these 4 types, and because a part of T-cell and NK cell lymphomas are EBV positive. Many of the post-transplant lymphomas are EBV positive, and a variable subset of primary CNS lymphomas are also EBV positive. And EBV positive lymphomas come fundamentally in 2 big buckets, so to speak. One are the lymphomas that develop in patients who have a dysfunctional immune system or so-called immunocompromised. Another one is patients who are not known to have a dysfunctional immune system, and they still develop EBV positive lymphoma. Very often, just a fraction of them. A great example is Hodgkin's lymphoma, which in the United States is associated with EBV about 30% of the times. And to the best of our knowledge, the patient with, except for those with HIV, but most patients with Hodgkin lymphoma are not immunocompromised. So we're going to start with primary CNS lymphomas. Its immunodeficiency certainly is a major risk factor for development of this lymphoma. And it can also occur in the setting of chronic immunosuppression, for example, after organ transplant, or patients with severe autoimmune diseases. For example, they have to take immunosuppression. However, I would say that probably the majority of the cases of primary CNS lymphoma that we see now are in patients who do not have a history of immune deficiency, and they're not taking any immunosuppressive drugs. Most of those are Epstein-Barr virus negative, and as opposed to the ones that develop after organ transplant or an immunodeficient patient. But so clearly there must be some kind of risk factor for the development of primary CNS lymphomas in patients who are not immunocompromised. And to the best of our knowledge, right now, those risk factors have not been identified. This is just an example of how these primary CNS lymphomas present. Very often, perhaps the most common symptom is confusion, some cognitive changes, memory, loss that people, significant memory loss, and the family and spouses and children that say mom or dad is just not behaving the way they used to. Another one is focal neurological deficit. So weakness, on just one limb or both, speech difficulties, loss of vision can be an issue, or abnormal vision, depending on the location in the brain. The only way to make a diagnosis is to really have a brain biopsy, which of course it's a complicated surgical procedure, which sometimes leads to some delays in the diagnosis. And of course, steroids are anti-inflammatory. One of the big issues with primary CNS lymphomas, which is shown in some of the pictures here, is the fact of this so-called, what we call it, midline shift. So the swelling of the brain is such, and there's not much space in the cranium, that the part of the brain shifts, through the midline, and that causes, high pressure and symptoms, and that's shown in these pictures. How do we manage primary CNS lymphomas? Well, for now, in terms of the newly diagnosed, the mainstay is a type of chemotherapy called methotrexate, which is given intravenously at high doses, has to be given in the hospital. There are also combinations with methotrexate, particularly a drug called cytarabine that is used in practice, but it's not clear that any combination as opposed to single agent really is superior to single agent methotrexate. And with that, it's a long treatment. Patients stay on treatment for months and months, and they have a high probability of achieving a complete response. However, the challenge for this is that the recurrence is high, as high as 50% within 5 years, and therefore a lot of patients come back with a recurrence of primary CNS lymphoma, and that's where a lot of research is going on. This includes clinical trials and a lot of work being done with CAR T-cell therapies, because these are DLBCLs, so they express CD19 and the CD20 for the bispecifics, and so immunotherapies now are being used. So I'm going to jump now to T-cell lymphomas, and I'm just going to use CTCL as an example. That's not because it's the most important one or is the most common one, even though it is more common than others. So I'm just going to show that even for a rare type of lymphoma, like cutaneous T-cell lymphoma, there are so many different variants that each one individually is considered ultra rare. This is just the list of the different types. Clinically speaking, this is a skin lymphoma, so being familiar with the different manifestations of CTCL in the skin is essential for the doctors taking care of this. And the way we frame our approach to these lymphomas is by looking at primarily by looking at the skin stage. That's always the first step, and the skin stage is listed there as T1, 2, 3, and 4. T stands for tumor. And it doesn't mean that you have a tumor, but for example, T1 is not a tumor technically. T1 is what we call a patch or a plaque. And then the changes between T1 and T4 depends on the amount of the surface of the skin that is affected, or at some point the development of really tumors, such as nodules, essentially. And if you look at the 10-year survival of patients with those different type of skin involvement, it is very different. People who have T1, they have 100% 10-year survival. People who have T3 OT4, they have much shorter survival at 10 years. One particular type of manifestation of CTCL, which I want to emphasize, is Sézary syndrome, because Sézary syndrome is definitely an ultra-rare type of T-cell lymphoma, and is recognized by, as shown here, there's another slide, by the presence of those weird-looking cells in the blood, and clinically by the presence of what we call erythroderma, so full-body redness, scaling, a terrific, incredible, severe itch as well. Now, this is CTCL in general, particularly mycosis fungoides, and on the right, there is kind of a probability of survival and progression with mycosis fungoides, depending on the stage. You can see that if you look at the bottom part of the graph, the patients who have early stage disease, they don't really have a very high risk of progressing. But patients who have, more advanced disease in the skin, they have a higher risk of progression. And the MF can, once it becomes more extensive in the skin, can actually go to lymph nodes, can go to the blood, and so on. For patients who have more advanced stage, there is now a collaborative group that is called the CLIC, Cutaneous Lymphoma International Consortium, and we've been part of it. And this group really developed a series of tools to predict prognosis in patients with more advanced stage, and that shows 3 groups there that have different prognosis. Now, Sézary syndrome is a very aggressive variant of cutaneous T-cell lymphoma and accounts only for about 2%. Okay, of all the cutaneous T-cell lymphomas, and it's a very aggressive, is very difficult to treat. Symptomatically is very difficult to have. Patients are often miserable. There are a lot of very good treatments now that have made it into the market, and there are other treatments that are in development. So I'm quite optimistic about our ability to really make a big difference with Sézary syndrome now, but it's been a difficult challenge. An example of a clinical trial in CTCL in general that really sort of made a huge impact is this Alcanza trial that was completed more than 5 years ago, 6 years ago. And this is a clinical trial that randomized patients to receive this new drug called brentuximab vedotin, which targets CD30 versus a standard of care. And this was a positive study in the sense that the brentuximab arm was superior to the standard of care. This led to the approval of brentuximab for the treatment of CTCL that expresses CD30. And some of them are a particular type of cutaneous lymphoma called anaplastic large lymphoma, but also a very, very significant fraction of mycosis fungoides, as shown here. Patients expresses some type of some degree of expression of CD30, and these patients have the patients respond to brentuximab. I think what was particularly interesting here, even though the number is very small, but patients with really very advanced stage of mycosis fungoides still had some good responses, and some that lasted. The ORR4 is a response that lasts more than 4 months before you can actually even count it. So a lot of those responses lasted longer. But just to be scored, they had to stay in remission for 4 months. So this is just a very successful example of a trial that made, this was practice changing, essentially. Another practice changing trial is Maverick that looked at the development of a monoclonal antibody that targets a antigen that is called CCR4. This Maverick also was completed, about 5 years ago, led to the approval. This drug is now approved in the US. We use it all the time for patients with CTCL. And this is particularly effective compared to brentuximab for patients with blood involvement, whether they have Sézary syndrome, which is a lot of blood involvement, or it's just minor blood involvement. And that's typically how we select patients to receive mogamulizumab. I'm going to switch gears now and go to post-transplant lymphomas, which, of course, is a completely different context, completely different background. So what are post-transplant lymphoproliferative disorders? Well, we've known them for 50 plus years. And essentially, ever since people started to be able to receive organ transplants. And in fact, I think the very first cases of PTLD were diagnosed in patients receiving liver transplants. And that was described in Pittsburgh, which was and still is a very large center, transplant center. But PTLD essentially is a growth of lymphoid cells, a lymphoid proliferation, or a full-blown lymphoma that develops as a consequence of the immunosuppression in a recipient of solid organ or bone marrow transplantation. From the standpoint of the biopsy and from the standpoint of the clinical course, it's a very heterogeneous group of diseases. I'm going to describe them in a minute. So first of all, how big is this problem? It's not huge, but it's not, it's not small either. If you look at the frequency here of cases of PTLD developing specific transplants, anywhere between 1% to 2% for kidney and pancreas, all the way to 12 to 20% for small bowels. A lot of it has to do with the intensity of the immunosuppression that people have to receive. So, for transplants that require very heavy duty immunosuppression, the risk is higher. For transplants where the immunosuppression is either shorter or less intense, the risk is lower. Perhaps the single greatest risk here for one of these PTLDs is the fact that the age of the patient, because young kids, and a lot of time, for example, small bowel transplants are done in kids. Those patients may not have been exposed to the Epstein-Barr virus before, so they are EBV seronegative, so to speak. And because the organs frequently are transplanted from adults, and almost every adult has been exposed to EBV, so now you are transplanting essentially EBV into a patient who has never seen it before, and on top of that is receiving immunosuppression. And that is primarily the main risk. Now, people still develop EBV positive PTLD even in adult age, but kids are the highest risk. We also divide PTLDs in two big categories, and we still do, even though this is a very old slide, but this is still true. One is we call early onset PTLD, so within a year of transplant. That's perhaps something that is not correct anymore. Here says the majority of cases. Actually, that now is a minority of cases. But almost all of them are EBV positive. They're frequently polymorphic or also called oligoclonal. So they don't quite have the full-blown lymphoma picture. And very often they respond to reduction of the immunosuppression. So, for example, a diagnosis of early onset PTLD is made. The first thing we do is to taper off to some degree the immunosuppression, so to kind of wake up the patient immune system. And this sometimes is sufficient to make these early onset PTLD go away. On the other hand, the late onset PTLD, which typically happen after a year or longer after the transplant, sometimes as late as 10 years, 8, 10 years. The incidence here says is increasing, and in fact, it has increased, and now they make the majority of the cases. More often are EBV negative, and that tells you something that that means that the reason for the development of these lymphomas perhaps is more similar to the reason why lymphomas in patients who don't have a transplant they develop. So they don't share necessarily the cause from EBV. And those are much more difficult to treat. They get treated exactly the same way as regular lymphomas, but they still have a very high mortality. So as again, risk factors listed here: primary EBV infection in a seronegative recipient, which essentially for the most part is young kids, a very high Epstein-Barr viral load, intensity of the immunosuppression, Sometimes graft rejection for patients get a bone marrow transplant, when the rejection of the graft or they develop graft versus host disease, that's the window of vulnerability, so to speak, of high. Perhaps CMV infection at the same time is a risk, which is not uncommon in transplant patients, and then other biological risk factors. This is the current classification of the PTLD. I'm not going to go through all of this. This is kind of a roadmap, so to speak, for the physicians to sort of, guide themselves through the differential diagnosis of all these different types. And these are just images and examples. The first column on the left, or the three pictures of biopsy, those are, so-called early lesions. And the one in the centers are the polymorphic ones, so kind of halfway through. And the one on the right is the monomorphic EBV positive. And the dots right here, the lower part shows the frequency of cells that are stained positive for EBV. You can actually see and detect EBV in the biopsy. That's how we know that the lymphoma is EBV positive. These are the outcomes for PTLD. This is a much more recent slide. So these are current outcomes with Rituxan, because once the immunosuppression is reduced, and if patients don't respond to that, then the next step is actually adding rituximab, because it's safe. Most of these are B-cell lymphomas or lymphoproliferative disorders, so rituximab works. And these are just kind of a series of outcome data from the literature. With the last two, the TRAPI, there are with the higher numbers. Those are very recent studies. And this is shown here. The TRAPI is from Europe. It's a consortium. He's the leader of a consortium in Europe. He ran this particular clinical trial. Was really kind of done sequentially. First patients trying reduction of immunosuppression, and then rituximab, and then chemotherapy with CHOP, and rituximab as well. And there are several different permutations of this approach. Whether depending on if you had a complete remission, continuing with rituximab. If you didn't have a complete remission, going with chemotherapy. Many times, patients with PTLD these days have to go through chemotherapy with R-CHOP. And this is just another part of the same. So this gives you perhaps a better idea of how we approach the PTLDs in terms of the workflow and the algorithm here. So for early lesions on the left, reduction of immunosuppression, very quickly, kind of assessing whether things are improving or not. If it is a complete response, perfect. If there's no complete response, depending on the stage, surgical resection, radiation therapy, single agent rituximab, then based on the response to rituximab, proceeding with additional chemotherapy as opposed to observation. And for the polymorphic and the monomorphic PTLD essentially is a diffuse large B-cell lymphoma, so we don't try single agent rituximab for those patients, and we just treat them straight with R-CHOP. I would say my experience, and even from the literature, the majority of the PTLDs that are seen these days are monomorphic PTLDs. So now I've been alluding to EBV off and on throughout the previous slides. Let's just take a quick look at exactly what EBV is. It's a fascinating virus that has been probably with human beings for millennia, potentially from the very beginning. And it's an extremely adaptable virus to humans. And it infects young adults or children, depending on the region. For example, in underdeveloped countries, the infection comes very early, and in developed countries, it happens much later. And that depends on the socioeconomic situation, exchanges and so on. But for the most part, it's transmitted through saliva. But once it establishes itself in the body, it becomes so-called latent. And so we all have it. 95% of the population eventually becomes EBV positive. And most people don't have any problem with it. The immune system controls the infection. The virus becomes dormant, silent, and doesn't cause any problem. However, in some cases, usually in association with either sort of situations where the immune system becomes weak, or people take something to suppress the immune system, or perhaps there is a congenital immune deficiency, or there is a dysregulation of the immune system. It's a very nuanced situation, but in those cases, sometimes people develop a cancer type, and the cancer types are listed there. So in patients who are known to have a defective immune system, for the most part, those are lymphomas, and they're listed there. I mean, HIV, for example, is a classical example of patients who have an acquired immune deficiency. The immune system doesn't work, EBV gets reactivated, and they develop lymphoma. Another one is the one that I just mentioned before, post-transplant lymphomas, and so on. Immune competent, it's a little more difficult to explain because the immune system in principle should be controlling EBV. So why is it that it doesn't? We don't know. What we know is that for most of these lymphomas, with two exceptions, it's not everybody who gets EBV positive. So for example, Hodgkin's, as I said, 20 to 30%. Gastric cancer, which is a very well-described EBV positive cancer, is about 10%. Burkitt lymphoma here in the US, the sporadic type, is 20%. But for some reason, nasopharyngeal carcinoma, which is not a blood cancer, and external NK lymphoma, they are 100% EBV positive. So we're still learning a lot about why that is. And it's a very active area of research right now. So EBV, Epstein-Barr virus. We're going to go to Epstein and Barr in just a minute, but Burkitt lymphoma was really discovered by Dr. Burkitt, who was a Royal Army Medical Corps physician in Uganda, and he did a lot of epidemiological work. Mapping out, as shown in this slide, the development of these particular type of lymphomas that were affecting children and big jaws tumors. And eventually he collected a sufficient number of specimens, and he was able to share them with Dr. Epstein and Dr. Barr, who were working in London. I don't know where Dr. A. Chong ended up because he was part of the original team. He didn't make it to the final naming of the virus, but looking at electron microscopy, they discovered that the specimens from tissue that Dr. Burkitt was sending them from Africa to London actually had this virus. And then the story kind of ends up here in Philadelphia because Dr. Henley at the University of Pennsylvania and his wife were studying infectious mononucleosis, and eventually they realized that the virus that Dr. Barr and Dr. Epstein had discovered was the same virus that was causing infection mononucleosis. So to make a long story short, that's how EBV was discovered, and eventually was clear that the EBV was responsible for Burkitt lymphoma. That was a first virus-associated lymphoma found, and then it was discovered that it was associated with a lot of other lymphomas and other type of cancers. Now, for us, for the medical community, and for my group in particular, and others, but EBV represents an opportunity because we have developed a way of actually leveraging the presence of EBV as a way to actually making the tumor cells that have EBV vulnerable to attack by a drug called ganciclovir. And I'm not going to go through this in great detail, just so you know that there is a clinical trial that was completed recently and was just published in all these different types of EBV positive lymphoma shown on the left. And it's a combination of drugs that we call, the approach we call a kick and kill. So the first step, the kick, is that there's a drug called nanatinostat that is an HDAC inhibitor that activates actually the lytic cycle of EBV in the cells that have EBV. And then, as a consequence of that activation, the cell starts producing some enzymes that activate the ganciclovir, which is a typically antiviral drug. Ganciclovir is activated and then is able to kill the EBV-containing tumor cell by inhibiting DNA synthesis. And so this was kind of a proof of principle study. Again, we just published it last year. And now there's another trial ongoing, not internationally, at this. This could be a potentially new treatment for EBV-associated lymphomas down the road, which is going to be potentially agnostic to the type of lymphoma that one has, as long as it has EBV. This is just the same. I'm gonna run through this. This just shows you the patients that were enrolled. It's a small study, so one will have to be very careful, and all of this will have to be confirmed, and will hopefully this trial that is ongoing right now, and then will be completed perhaps in a year or two, will give us the final information. But these are very promising treatment. And we saw responses in all different kinds of lymphomas, DLBCL, and the peripheral T-cell lymphoma. Those are the two types of lymphomas where we seem to see the better responses. And this shows the same thing. So I'm kind of going down to the final stretch here of this talk. And because we've been talking about immunosuppression, we've been talking about T-cell, NK cell, EBV, and so on, I wanted to highlight some information which may or may not be familiar to some of you, and which is not necessarily specific for lymphoma, but lymphomas are part of this spectrum. And that is, these are WHO organization so internationally, that actually keeps track of all the cancers related to infections. They publish every 6 to 8 years. They publish a new study. It's called GlobalCan, so global cancer and cancer related to infection. This is from the data from 2012. There's a more recent one from I think 2018 or 2019, but the numbers are, and the breakdown is fairly similar. Bottom line is that, a significant fraction of cancers worldwide are really attributable to infections. In many cases, these infections are things like Helicobacter pylori, for example, that can cause gastric cancer, or they can be some type of odd parasite like schistosoma hematobium, or some of these other impossible to pronounce names. But a good bunch of them are viruses, so human papillomavirus, HPV, that causes cervical cancer, or head and neck cancer, hepatitis B, huge, hepatitis C, and of course we see Epstein-Barr virus there as well. So if you put them all together, talking about rare, cancer individually, but then in aggregate, this is a huge problem. And I think one of the obvious sort of conclusion is that these cancers should be preventable, if we know how to diagnose them early, or we can figure out who's at risk. I mean, the most obvious one is hepatitis B. There is a vaccine for hepatitis B, and we know that hepatitis B vaccination prevents liver cancer, possibly lymphoma too. So the only reason why hepatitis B remains a problem is because people don't get the vaccine. On the other hand, hepatitis C, there's no vaccine for hepatitis C, but hepatitis C now is curable with drugs. So the problem there is different. It's not that there's vaccine, people don't get the vaccine, is that people don't have access to the hepatitis C curative therapy, which is very expensive. When we look specifically at lymphoma, you can see here that there's a substantial number of lymphomas that actually are related to viruses. And hepatitis C, this is global data. These are not United States data, but hepatitis C clearly is associated with a great number of B-cell lymphomas, particularly marginal zone lymphoma. Then, of course, adult T-cell leukemia lymphoma, it's a T-cell lymphoma related to HTLV1. So digging now deeper on the B cell, this is, some diffuse large B cell lymphoma are associated with Epstein-Barr virus. That is clear. The question is what fraction of them, and the data are all over the place, in part because people are looking at EBV in different ways. So, you're kind of comparing apples and oranges here. However, this is a very good study just done recently. And this shows that at least in France, about 4% of all the DLBCLs are EBV associated. Now, you could say, okay, so what? I mean, 4% is a very small fraction. The issue is that these lymphomas are more frequent in the very aggressive type. So people who are older, they have, they're frail. They have advanced stage DLBCL. If you put all those together, probably the fraction of EBV positive lymphomas is higher in the group. So it's very important that we become familiar with this particular type. Is recognized by the 2022 WHO classification and the ICC classification. So this is a formal entity that is well known. It's just that here in the West is not very common. And for example, when we test EBV in every DLBCL, and I think that everybody should, have their tissue test for EBV because, number one, it informs kind of the prognosis. Number two, now there are, as I showed in the previous slides, there are trials and treatments in development specifically for EBV positive lymphomas. So very important study here from France. People also look, this is from Germany, people also looked at the genetics of these lymphomas, and this is a very complicated slide. I'm not going to go through it in detail, but I guess perhaps the point that I want to make is this. If you look at the lower bottom panel, you will see that there are two pie charts, okay? The pie chart on the left shows in black, red, and pink the lymphomas, the DLBCLs that are EBV positive that we can fit into a known genetic group with this lymphogen 2, which is the most recent genetic classification of DLBCL. So only 20% of the EBV positive lymphomas can be classified by one of those 4 or 5 groups. All the other ones cannot be classified. So we have a huge black box of genetic unknown that are much more common in EBV positive DLBCL compared to that. So there's a lot of biology there to be discovered, and a lot of learning that has to happen so that we can actually treat these lymphomas more effectively. Another virus that I mentioned briefly that causes ultra-rare type of lymphoma, in this case a T-cell lymphoma, is HTLV1. It's something probably most people on this call are not familiar with because it's not something that comes up in the news very often. But it's a very common virus in certain parts of the world, particularly the Caribbean, South America, Brazil, for example, as shown in the picture there, the Andes, so Colombia, Peru, Ecuador, and then West Africa. And then, of all places, Iran, for some reason, has a high incidence of this virus in very specific regions in Japan. I'm not sure we know how this geography really is caused, but the bottom line is that in some areas, the prevalence of this virus is quite high. Sometimes up to 10% of the population can have the virus. And if you have the virus, you have a lifetime risk of developing this type of lymphoma, leukemia called AT, adult T-cell leukemia lymphoma. Now, the risk is not very high. So if you are HTLV1 positive, probably the lifetime risk is 5, perhaps 7% max. But of course, it's significantly higher risk of developing a blood cancer compared to not having the virus. The other issue is that when this lymphoma is diagnosed, the prognosis is very challenging. These are lymphomas that are very difficult to treat, very resistant to chemotherapy. So this is a huge unmet need. This is another lymphoma where possibly some type of prevention or early diagnosis. Prevention is hard because the main modality of transmission of this virus, interesting enough, is breastfeeding. So it can also be transmitted, of course, with all the other ways, sexually transmitted, blood products, and everything else. But at the population level, in the real world, most people get infected by breastfeeding. So there are campaigns to try to prevent, transmission through breastfeeding, but it never works. So preventing it is difficult. I think perhaps early diagnosis could be a little easier, and then especially if you can find something to treat early on. So a couple of additional viruses here, since we're on the virus talk. Hepatitis B, as I mentioned, it's a huge problem worldwide. There is a vaccine, but people don't get it, and including here in the United States, by the way. And of course, lifetime, people who have chronic hepatitis B, they have a very high lifetime risk of developing liver cancer. That's the highest. I think it's shown there, 80-fold risk of hepatitis B developing hepatocellular carcinoma, HCC. Now, these patients with chronic hepatitis B also have a high risk of developing diffuse large B-cell lymphoma. That's something that even the Hepatitis B Foundation didn't know, interestingly enough, here in Philadelphia, because here in Philadelphia, there's a huge problem of chronic hepatitis, as shown on the right. We have approached the Hepatitis B Foundation, which is located here in Philadelphia, and now we're sort of talking and having good discussions, but somehow they didn't know that hepatitis B increases the risk of lymphoma. And if you have a hepatitis B associated lymphoma compared to hepatitis B negative lymphoma, the prognosis is worse. Okay. Now, this may have nothing to do with the lymphoma itself. Perhaps it's worse because having chronic hepatitis B, your liver function is no good, you have other comorbidities. This doesn't mean that the hepatitis itself is driving the prognosis. But nonetheless, if you look at hepatitis B positive versus negative patients, the prognosis is worse. Finally, hepatitis C. I did mention in a previous slide that hepatitis C is responsible for a significant number of lymphomas specifically. And this is just kind of a global map of the prevalence of hepatitis C infection, another huge problem worldwide. Hepatitis C virus, just like hepatitis B, is a very important risk factor for liver cancer. It is also an important risk factor for lymphoma, although not comparable to liver cancer, and in particular for marginal zone lymphoma. For example, patients who have splenic marginal zone lymphoma, which is one of those ultra-rare B-cell lymphomas, a good number of them is associated with hepatitis C, either past hepatitis C or chronic active hepatitis C. Hepatitis C is curable now with antiviral therapy, but again, it's access to that therapy is the major issue, particularly in countries, low-income countries that they don't have the resources. I'm going to skip this. It's not. Now, their hepatitis C lymphomas. Hepatitis C is also seen in diffuse large B-cell lymphoma. Perhaps these are diffuse large B-cell lymphomas that develop as a transformation from marginal lymphoma. Is possible. And in some cases, it's true. It's just not all cases. So it's possible that also DLBCL may develop just right off the bat. There are not many studies. This is only one that really kind of looked at the genetics of these lymphomas. And to make a long story short, there are differences. For example, BCL2 translocation frequency is much less to non-existent in hepatitis C associated diffuse large B-cell lymphoma compared to hepatitis C negative. And the only reason I'm showing this slide is to show that the biology of these lymphomas is different. And right now, none of this is taken into account by our classification of diffuse large B-cell lymphoma. So what's the message here? Something that you already know because you're on this webinar here and you're already kind of working with the LRF, but important to take action and become empowered here. Find patient advocacy organizations. The LRF is a great example that support research and education of disease. Join them, help them. If no organization exists, find others like you, advocate for more research, be focused on your disease, partner with your doctors and care team, and be loud. And then in every way possible, support and participate in research, because that's the only way we can actually make progress. Talk to others, encourage them to participate. And if you can't support research, at Jefferson, I apologize, I had this slide, I forget to delete, but by all means, this means support research anywhere you can. And if you cannot help yourself, find someone who can. And with that, I'm happy to take questions. I think we have almost an hour time for questions, so plenty of time. Thank you very much and for staying on. Appreciate it. I'm going to stop sharing now.
Perfect. Thank you so much, Dr. Porcu. Like you mentioned, we're going to jump into questions. That was an excellent presentation. We did have some questions that were sent in beforehand that we're going to start with some of those, and then we'll jump into some of the questions in the Q&A box. But by all means, if you do have a question, please continue to send those in through the Q&A box.
Yeah.
So starting with our first question here, this patient has splenic marginal zone lymphoma now in the central nervous system, and they're taking zanubrutinib.
Yep.
And they have some leg swelling, but they don't know the reason why. Do you have any thoughts as to why that might be?
It's a good question. It's a practical question regarding zanubrutinib, and which is used for a lot of different type of B-cell lymphomas, of course, including marginal zone lymphoma. It's definitely a good drug for marginal zone lymphoma. Generally, zanubrutinib is obviously is a BTK inhibitor. It's a second generation BTK inhibitor, has a toxicity profile that is better than the initial BTK inhibitor, ibrutinib, which was a lot of off-target effects on other kinases. And therefore, some of the cardiovascular sort of toxicity that ibrutinib has, such as high blood pressure, atrial fibrillation, and so on, the risk of those is less. Now, edema, which means swelling and due to fluid retention in the legs, is not kind of a typical toxicity, even of ibrutinib, although it could happen secondarily if you have congestive heart failure due to atrial fibrillation, for example. I think that in cases where of course, it's kind of hard to know specifically, but if the patient is saying that the splenic marginal lymphoma is advanced, right, in terms of stage, is affecting the CNS, this would make me think that the splenic marginal lymphoma is, either transformed or has evolved into a more aggressive type, and therefore, in those cases, inflammation, cytokine release, maybe a little bit of a vascular leak. It could be related to lymphoma, but not the treatment necessarily, the lymphoma. Or it could be something completely unrelated to the lymphoma either, and therefore, being associated with either, fluid overload, retention from any other reasons.
Thank you very much. Our next question here is from a patient who is 12 years post-kidney transplant and had EBV negative B-cell PTLD.
Yes.
And their question is, how do we manage immunosuppressant medications after treatment and remission? Is there any surveillance or ways to be active in care going forward?
Yeah, that is a terrific question, because that is one of the big sort of challenges in managing post-transplant lymphoma, something I didn't really have the time to discuss in detail, but except for saying that we try to reduce it. But so it's a couple of big picture points here. One is that the requirement for immunosuppression so far out after an organ transplant often it changes. And I'm tempted to say could be less or decreased. The challenge is that the management of the responsibility and the privilege of managing immunosuppression in patients after transplant really is entirely in the hands of the transplant doctors. Transplant doctors have evolved sort of standardized approaches to immunosuppression that have been keeping patients safe and organs safe for a very long time. So they're very careful about not changing their procedures too drastically or too quickly, because there's a lot at stake. And therefore, the conversations, for example, between the oncologist managing the lymphoma doctor managing the PTLD and the transplant team, those conversations always are they have to be calibrated very, very carefully, because we want to maintain the best possible chance for the organ. In some cases, there's no option of sort of manipulating, because if you have a liver transplant, for example, even a little bit of rejection, may not be safe at all. So there's no dialysis after failure of a liver transplant, obviously. So I think that those conversations are challenging. I would say the one thing I can say is that I always try to talk to the transplant doctors and get a sense of how important they feel maintaining a degree of immunosuppression is so far out. That's one big picture. The other big picture, which is almost like the mirror aspect of that, is that because, as in this particular patient and in many others so late, the PTLD is EBV negative. And the one thing we know is that manipulating the immunosuppression when the PTLD is EBV negative may actually not be that hugely important as it is in the early PTLDs, where EBV clearly is the cause and the driver of the PTLD. So we always try to minimize it if possible, but it may not be a game changer, changing immunosuppression in patients who have late PTLD EBV negative. It's a huge question, and always a practical challenge. Yeah.
Thank you. The next question here is, I was diagnosed with EBV back in 1995 and was told it was chronic, since my titers were extremely high for a few years. They then told me it was CFS and fibromyalgia. I never really recovered. But in 2018, I was diagnosed with MCL and CLL. I've read it's related to the EBV. Do you know anything about the possible connection?
Thanks for the question. I think it's a fascinating story. And the one thing that would be helpful to know, which we may not know, or even perhaps the patient on the call may not know, is that, but is really critically important, is this high titer of EBV. What does it mean? Because EBV is, can be tested in a number of different ways, and the way you test it tells you something about what EBV may be doing or not doing. So, for example, if high titer means that antibodies against EBV, which we all have because we've been exposed to EBV, that those titers were elevated, that doesn't necessarily mean that the EBV was sort of acting up, or causing problems. On the other hand, if high titer means that blood tests show that the virus itself was active, and this is called viral load in lay terms, then actually that would mean something different. It would make it much more likely that at least at the time those titers were elevated, that the virus was causing some problem. So that's point number one. Point number two is the issue of the mantle cell lymphoma and the CLL, which typically is not. Those are not two type of lymphomas that typically are considered to be associated with EBV. Although to be fair, any lymphoma in some patients could be associated with EBV, but is not the majority. So so mantle cell lymphoma and CLL may have nothing to do with the EBV that was detected. So that's the best I can say. The chronic EBV, that's always a challenging situation because people tend to put together a lot of different symptoms. The fibromyalgia is a classical one, and it's very hard to know what EBV actually does in those patients, how the fibromyalgia may be related to the EBV.
Thank you. The next question here is, my husband was diagnosed with early stage extranodal NK T-cell lymphoma, nasal type, in August of 2021.
Mm-hmm.
He completed PGEM-OX and radiation treatment in May of 2022, 3 subsequent PET scans showing no evidence of disease. The question is it possible for this type of lymphoma to reappear as very small lesions on the thoracic spine? Radiologists recently identified 4 new lesions after an MRI and CT scan of the spine and pelvic area. And a PET scan is scheduled for late March. They're wondering if you might have any inclinations.
Yeah, very, very, very tough to really kind of answer this question in a meaningful way. I guess one way to potentially answer the question would be, is it possible that somebody who had NK T-cell lymphoma in 2022 and possibly no other symptoms, that's the way I understand it, might actually have the lymphoma recurring just with some abnormalities of the spine, just found on MRI, in the absence of any other symptoms? That would be fairly odd, I would say. So it's just seeing those things is not something the red flags will go immediately up. At the end of the day, though, we've learned that prudence and sort of being diligent is the key always. So if something, of course, there's a lot of anxiety that goes along with that, and that part is difficult to manage. But I think that certainly the PET scan is going to be particularly helpful here. The MRI itself may not be. Or CAT scan may not be, but a PET scan will be helpful. Something else that we always do is that, I don't know if it was done or used for the diagnosis, but whether the Epstein-Barr virus load, the viral load in the blood was elevated, whether, the viral load is now active, detectable again. I use EBV viral loads exactly like that. So I keep monitoring every time. And when people are in remission, particularly with NK lymphoma, which is a great example for how that can be helpful, it's if the EBV was elevated before treatment, becomes, disappears when people are in remission, and then you monitor over time, and at some point you see that EBV level going up, that is a red flag, right? And the EBV goes up, and there is something on the MRI. Then the red flag goes up, and then that doesn't prove that the lymphoma is back by far, because EBV can be elevated for other reasons. But certainly it would be a reason to pay a lot of attention to what's going on, and therefore pursue more testing. Yeah. I hope that answered the question. Yeah.
Thank you for the insight in any case. And next up, a patient writes that they've been a Waldenstrom patient since 2004. They've had 11 rounds of fludarabine radiation in 2016 for a tumor and subsequent rituximab in 2019.
Mm-hmm.
They're looking back at how their nervous system was being attacked by, and mobility got worse and worse from 2021 to a complete shutdown in 2024.
Mm-hmm.
So their first question is, how do you detect when the central nervous system is being attacked? Because theirs wasn't diagnosed until they had almost no mobility left in their legs.
That's a tough one. And, you know, generally, the way doctors, including myself, we approach things in question is to some degree, by pattern, and I would be tempted to say prejudice, pattern and prejudice, right? So in the sense that we like to put things together in a certain pattern, and if we see the pattern, we tend to pay attention to draw certain conclusions. And quote unquote, prejudice means that what do we know about a certain disease that would tell us if it is more likely or less likely that for something to happen, right? So, for example, for aggressive lymphomas, especially if they are very advanced stage, looking at the possibility of the central nervous system being involved, that's always high on our mind. We always worry about it. We always look for it. If there are any clues or suspicions, and we pay a lot of attention. But for Waldenstrom, that is not the most common situation. Although, in all fairness, the gentleman or the patient here had Waldenstrom in 2004, so that's kind of 20 years ago. So anything can happen 20 years later. The fludarabine is a drug that actually has as potential side effects some central nervous system side effects. So I guess if one would want to be sure that what happened to this patient was really related to the Waldenstrom and not necessarily a late effect of the fludarabine. But let's say it's a lymphoma. So then I think, the way we look at it is by looking at symptoms. I don't know, here we're talking about mobility, so I'm assuming their weakness perhaps, or, use of the lower extremities. Certainly. Then what we do is to try to detect it early. The first thing to do is, of course, an MRI. Then very often in lymphoma, we do a spinal tap to see whether we can detect the cells. Sometimes Waldenstrom and other lymphomas that are associated with abnormal proteins, like the M protein, the monoclonal protein, and they actually have some bizarre neurological symptoms associated specifically with the presence of these monoclonal proteins. And therefore they have kind of specific syndromes. But I don't know if this is something that applies to this particular patient or not. The way to look at it is, clinical, paying attention to the symptoms, a very careful physical examination, for anything suspicious, MRI of the brain and the spinal cord, and then if necessary, doing a spinal tap. Those are the key. Yeah.
Thank you. And their follow-up question would be, do you have any insight on the best way to have success at CNS repair?
Any idea on the best way to be successful at CNS repair? I have to admit that I don't know what CNS repair means. Right. If we're talking about recovery of function of the CNS, that's a huge question, that I may not even be competent to answer. But I just don't understand what the CNS repair means. If the person is able and willing to clarify the question in the chat, I'm happy to take another stab at it. But as it is, I don't know.
Certainly, if I notice that, I will bring it back up to you. Jumping into the next question here, what is the consensus regarding the long-term 2 to 3 year treatment plan of rituximab for patients with stage 4 mantle cell lymphoma?
Terrific. And little difficult question, but you know, it's the reason is that I mean, I would say this, maybe difficult or simple, depends. The consensus right now in mantle cell lymphoma is that maintenance rituximab adds value, okay, to the treatment, whether it's after the auto transplant. I think that there are very good data for that, but also from a clinical trial, but also in patients who get first BR, bendamustine and Rituxan, as part of their treatment. And that doesn't come from a clinical trial, that comes from more of a retrospective analysis, of patients who received it. So I would say that the consensus is that clearly maintenance rituximab helps in mantle cell lymphoma. The reason why I was saying it's a little challenging is because it's not clear exactly what the best regimen to do maintenance rituximab is. Meaning it could be that perhaps a shorter duration of rituximab, instead of 3 years, it's a way to go. And I don't think we just have all the data necessary to conclude that, particularly after bendamustine and Rituxan, I would say, where there's no trial. So.
Thank you. We're now going to jump into the questions in the Q&A box here. So starting off with the first one, is cardiotoxicity following chemo curable?
That's a terrific question. So it depends, as usual, right? I mean, it depends to some on the severity of the cardiotoxicity. I can tell you this. I can tell you that I have seen patients, for example, who developed a cardiomyopathy from chemotherapy, particularly R-CHOP. And they developed significant cardiomyopathy. So there was, dysfunctional and, affecting their quality of life and ability to do things, a high severity score. And those patients, some of those patients had actually good outcomes with pacemaker-based therapy. I remember specifically I'm at Jefferson now in Philadelphia, but I had a patient at Ohio State many, many years ago that actually developed cardiomyopathy and severe cardiomyopathy, and cardiology. They saw him, of course, and they were helping out. And at some point, a clinical trial became available of pacemaker therapy for congenital heart failure. And this patient was reborn. I mean, I've never seen anything like this. I mean, he went on to be, of all things, well, I don't want to share too much information on this patient on a webinar, but essentially he became from being really debilitated to being able to do just about anything that he wanted to do, physically speaking, right? Climbing, dancing, anything. And it was just amazing. So did every single patient go like that? No, but it is possible. And my advice would be, most large cancer centers these days have somebody in cardiology who does so-called cardio oncology. So these are cardiologists that really specialize in following patients who have cancer and getting chemotherapy. And if there is any clinical trial that involves either new drugs or pacemaker therapy, I would encourage strongly the patient to actually pursue some of that.
Thank you. Next up is, how common is duodenal follicular lymphoma in people under the age of 40?
Not very. That's the easy part. Give you a number. I'm not even sure I can come up with a specific number. This is one of those ultra rare lymphomas. Okay, and my guess would be that probably that makes maybe 1 to 2%, maybe 1 to 3% of all the follicular lymphomas. Right? I don't think there's more than that. And then regarding the age, to be honest, I don't know how to compute the age into that calculation. I had several patients with duodenal follicular lymphoma. I know they tend to be younger, but a lot of the patients that I had were in their 50s, so not necessarily in the 40s. The one thing I know is that I believe it doesn't make a difference whether you're, younger or, more, younger than 50 or older than 50. It's a very favorable prognosis no matter what. So.
You. Next up is, where is the best place to get up-to-date info on NLPHL? There doesn't even seem to be consensus on whether it's curable, much less how aggressively to treat and when to treat.
Right. So another great question. NLPHL, for those who don't know in the audience, is a nodular lymphocyte predominant Hodgkin's lymphoma, which now we know actually is a non-Hodgkin lymphoma. So it's kind of a little weird that we're still calling it Hodgkin lymphoma. At the end of the day, doesn't matter what we call it. These names change eventually. But the patient on the call is correct. It's a type of lymphoma that tends to fall, between the cracks. Because it's a rare lymphoma. And there's not a whole lot of information. I mean, I know that the LRF is a good place to go for information about anything, and whether or not it is information that is, I don't know exactly a specific nodular LP Hodgkin lymphoma guide. I have to admit. I'm sure there is something in the Hodgkin lymphoma booklet for sure about nodular lymphocyte predominant. But I would say the best would be, if I were a patient, I would still go to the LRF or any other patient advocacy organization that focuses on lymphoma and try to actually get engaged with either investigators, doctors, education forums. That's probably the best way to really get accurate information on that. There's not much else. You're correct. In terms of education, patient education. The good news is that nodular P Hodgkin lymphoma is a very favorable type of lymphoma. For the vast majority of the patients, people still need to get some treatment sometime, and sometimes they have to get chemotherapy, but usually the outcomes are very good.
Great, thank you. The next participant wrote in to thank you for your dedication and passion for rare cancer research and CTCL in particular, and they're wondering why you chose to study rare cancers and what can be done to encourage more clinicians to make rare cancer their main practice research.
Wow, great question. I guess for me it was a process. I started with a specific interest in T-cell lymphoma in general, including CTCL. Actually, T-cell lymphoma. Then by doing T-cell lymphoma, the reason why I was interested was primarily the science and the biology of the disease that I found kind of intriguing. But then I realized that I started doing this in 2000, and the first paper I published in T-cell lymphoma was in 2003. So we're talking about 21 years ago. And I realized that there wasn't much in T-cell lymphoma in those days. To me, that always serves as a motivation. I like to to do things where there's a lot of need. And so that's how I started. Then by doing T-cell lymphoma, I had to learn all about cutaneous T-cell lymphoma, which of course I knew nothing about it before starting. And then I realized how interesting that, and then the population, for the most part, I would say this, is the fact that I feel that people need help, and I want to help. That perhaps, from the human motivation, that I hate when people don't know where to go, they don't know where to turn. I hate when people don't have somebody to talk to. That's really, at the human level, that's the motivation. And then from the scientific standpoint, I just feel that rare diseases are an incredible opportunity to actually make an impact in cancer. So scientifically, that's a reason. Yeah.
Thank you so much for sharing that. And next up is my partner was diagnosed with Waldenstrom's macroglobulinemia in 2017. He presented with a mild elevation of IgM, enlarged spleen, and an elevated IgG.
Mm.
Since treatment, his IgM has remained normal, but his IgG has returned to an abnormal level. A biopsy of a lymphoid tissue due to another cancer shows amyloid deposits.
Mm.
Does he have a rare type of Waldenstrom or a secondary LPL?
Yeah, that's a great question. And the short answer is I don't know, obviously for sure. I mean, I think that the fact that there was a second monoclonal spike, suggests that this was more of a composite type of lymphoproliferative disorder or lymphoma. And that is not is not super rare. That can happen both on the myeloma side as well as the lymphoma side. There is overlap, right? And in some cases, people have more than one monoclonal component. And without having any additional details about the amount of the monoclonal proteins and so on, the type of disease that was found in bone marrow, it's difficult to say anything meaningful about the amyloid. But the amyloid, I would, typically is something related to light chains. In patients with Waldenstrom don't often have a light chain problem. Is more like the intact IgM that is the product of the lymphoplasmacytic lymphoma. So perhaps this is a situation where there was a lymphoplasmacytic lymphoma with Waldenstrom and elevated IgM. It got treated, and there was, in the background, there was another type of, plasma cell disorder leading to a monoclonal IgM. And over time, that caused amyloid deposition. Of course, all depends on the severity of the amyloid. I mean, is that amyloid incidentally found on a bone marrow biopsy, which is not unusual, or is more symptomatic amyloid and so on? Kind of hard to know just from the little information, but it's not something that I would say, wow, impossible, or we've never seen that before. It's just that it's not your typical straight up Waldenstrom, so that requires some careful attention to exactly what's going on in the marrow, particularly.
Thank you. Our next question here is, has EBV-associated lymphoma been connected to COVID or the vaccine? Has there been an increase since the pandemic?
Yeah, that's another great question. The short answer is no, that we know of. I mean, data, even we've been dealing with COVID, of course, now for at least 3 full years. So some information on trends, of certain diseases before and after COVID are starting to come up, but it's still early, right, to see if we were to see any kind of major change. So as of now, I'm not aware of any change in the kind of the frequency or the incidence of EBV lymphomas with COVID. And I think that what we know is that COVID clearly, particularly severe cases, are associated with an immune dysregulation, cytokine release, and probably some immune suppression as well, the disease itself. And in that kind of environment, it's not impossible to have actually reactivation of EBV. So I can see how somebody who has COVID perhaps multiple times at some point may develop an EBV positive lymphoma, and that the two things might be related, sure. But at the population level, so like big numbers, and say, okay, since COVID, we've seen a certain increase in the number. No, definitely, I'm not aware of anything like that.
Thank you. The next question here is, I couldn't get to the entire program, but I have ALL. Some say I have lymphoma and others say leukemia.
Mhm.
What do I have and how is treatment different?
Um, Yeah, it's you see that I had a slide at the very beginning say what's the difference with leukemia lymphoma. This is a perfect example why that slide remains important. So I think that there are a couple of possibilities here. I would say the most likely and perhaps the simplest situation here is that there are two forms of ALL, that are kind of mirror images of each other, so to speak. One is ALL, the other one is called lymphoblastic lymphoma, LBL. It's almost exactly the same disease. It's kind of the same thing as CLL and SLL. That's probably the best example, chronic lymphocytic leukemia and small lymphocytic lymphoma. It's the same disease, just two slightly different manifestations of it. And the same is true for ALL and lymphoblastic lymphoma. So depending on, the presentation, for example, a lot of times when people have lymphoblastic lymphoma, they have a large tumor in their chest. And I apologize, I have a cat here in the background. So if you hear the meow, it's my cat. So perhaps that would be the simplest explanation. So perhaps, somebody told you that you have lymphoblastic lymphoma, somebody told you that you have ALL. It's the same thing, essentially. That's probably what this is about.
Thank you. The next question here is, do you recommend the general public to get the hepatitis B vaccine for prevention?
So that's a great question. Right now, the answer is no. I mean, I think the CDC recommends hepatitis B vaccination for people who are exposed to a certain risk. So all healthcare providers, for example, have are required to get hepatitis B vaccine. All the medical students, nursing, doctors, and so on. And to the best of my knowledge, the CDC has not revised those indicators, or there's any other risk factors. But again, to the best of my knowledge, there hasn't been a change yet in the recommendations for the vaccine.
Thank you so much. Next up is, what does it mean to be a T-cell lymphoma expert, and is the treatment for T-cell lymphoma standardized?
Wow. I guess you are an expert in something when somebody else tells you that you are. I mean, so it's usually, especially if it is a more than one person. If your mom tells you that you're an expert in T-cell lymphoma, probably that's not enough. But if a bunch of peers, and other doctors, they all agree that somebody is an expert in something, that's probably true. So it's really about peer review and evaluation. I think at the end of the day, expertise in anything is something that only comes from the fact that you do that day in, day out. And you cannot be an expert in anything if you do that, once a month or twice a year. So there's a question, there's an issue of volume, how busy you are and so on. The reason is for expertise is that you just see more of a particular type of disease, and we know that still direct boots on the ground practice is a very important part of being a doctor, an oncologist, and a lymphoma expert in this disease. And so that's where the expertise comes in.
Thank you. Next up is, what is the likelihood of lymphoma recurring after rituximab and chemo treatment for EBV positive CHL? Or what is the likelihood of relapse in EBV?
And I'm assuming CHL means classical Hodgkin lymphoma in this particular question, I suspect. Yeah. Yeah. Well, depends on the stage, right? I mean, because EBV in Hodgkin lymphoma is associated with a higher risk of recurrence. It's complicated, but there are data from a clinical trial that was completed, many years ago, by ECOG, which is one of the cooperative groups here in the US. One of the things that they looked at was, patients who had detectable EBV at the initial diagnosis, and then how they did compared to everybody else at the end. And their progression-free survival, which is the survival without the recurrence, was lower compared to the rest. But again, if you have early stage classical Hodgkin lymphoma, that risk is still very low. And even if you have advanced stage Hodgkin lymphoma, the risk is still relatively low because, all things considered, classical Hodgkin lymphoma treated appropriately still has a very high cure rate and low risk of recurrence. So one would have to kind of dig into the details of, what the stage was, the risk factor, the prognostic score, and all that. The EBV is only one component of, even not even officially, it's a component of that, So just a small impact, I would say.
Thank you. The next participant writes, I have indolent follicular lymphoma, which has moved into my central nervous system, and I'm taking Revlimid. Is this very rare? And do you have any observations?
Yeah. So certainly CNS involvement with follicular lymphoma is not common. And so, yeah, I would agree that it is very rare. So here's another interesting sort of way of looking at rare, in lymphoma, is there are certain lymphomas that are specifically rare or ultra rare by just the nature of the lymphomas that they are. And then there are lymphomas that may not be rare, but you have the rare presentation, right? Or you have the rare complication, or you have the rare manifestation or relapse, which to some degree this has to do with that. The same is for the Waldenstrom question about the CNS. And these are, of course, very important, very important questions because odd or rare things happen even in common diseases. And so, yes, it is an uncommon presentation. There are two ways that this could happen. One is the follicular lymphoma is so-called transformed, because that is something that happens on a regular basis in follicular lymphoma, so large cell transformation. And when that happens, then involvement of the central nervous system is actually not that uncommon. So where it would be a very uncommon situation, very rare situation, is if the follicular lymphoma is still indolent and not transformed, and you have involvement of the CNS. That would be uncommon. Revlimid sounds like a good drug to pick for something like that because Revlimid crosses the blood-brain barrier. So you would expect it to have some effect. And also that suggests to me that your doctors are probably thinking that it is not transformed, because if it was transformed, they would probably treat you with more aggressive chemotherapy.
Thank you. Sticking with follicular here, how many cases have you heard of where follicular indolent B-cell NHL transformed into nodular sclerotic classical Hodgkin lymphoma?
Oh, wow. I would say a handful. I mean, it is, it is not, is not very common. Now, this question, though, raises a very important big picture question about lymphoma, something that I have a specific slide that I show, although not in this case because this was a different talk. But, I always like to show a slide about 3 things that I bet you didn't know about lymphoma, And one of those 3 things is the fact that lymphomas can be composite, or they can morph from one type to another. And so this seems to be one of those cases. The transition from follicular lymphoma to nodular LP Hodgkin's, I think that's what I heard from, or nodular sclerosis, which was nodular sclerosis.
Nodular sclerosis.
Yeah, so that's even less common. But so that transition, it is odd, I have to say. But the bottom line is that anything can happen in lymphoma, because lymphomas are very, there's a lot of plasticity. The one thing is always good to do when the first diagnosis that leads to a different diagnosis later on, this is just due diligence, is you want to make sure that the diagnosis the first time was correct, which is not easy to mix up follicular lymphoma with nodular sclerosis Hodgkin lymphoma. I think that seems pretty unlikely, but it always calls for a little bit of a double check on what was, how was the first diagnosis made versus the second. Having said that, transitions happen all the time. So it doesn't mean that the first diagnosis was wrong. It could easily be right. And this just happens to be one of those situations where the lymphoma evolves from one type to the next.
Great, thank you. The next question here is, how would you treat T-cell rich B-cell that has relapsed?
Yeah, very good question. The way we treat T-cell rich, histiocyte rich B-cell lymphoma, which is the full name, is we treat it exactly the same as any other diffuse large B-cell lymphoma. So, for a relapse T-cell rich B-cell lymphoma, we would go through our typical, we call it algorithm or flow chart, so to speak, for treatment for relapse DLBCL, which means depends on how soon the relapse has occurred. If this recurrence was within 12 months, it's a high-risk relapse. Sometimes, patients now these days get treated with CAR T-cell therapy, when they relapse so quickly. If the relapse occurs after, longer than a year, then there are a lot of other options. You could, potentially do, the plenty of bispecifics these days, or sort of second-line therapy with any of the approved therapies for second line, including chemotherapy with stem cell transplant. So the sky is the limit as far as options for therapy at first relapse. There's no, the only distinction is how quickly the lymphoma came back, within 12 months or after 12 months.
Thank you very much. The next participant here writes that they're a 23-year-old male with stage 2 DLBCL in the lungs, EBV positive. They completed R-CHOP 3 months ago. They're doing regular labs and scans now, and they're wondering if you have any thoughts or recommendations in this situation.
So let me make sure I had this right. So the person asking is young, 23 years old, has an EBV positive DLBCL. The stage is a little questionable because, if the disease is in the lungs, there would be stage 4 and not stage 2. So unless it is in the chest and not necessarily in the lungs tissue, and of course, there's no way to know. But let's say that this is stage 2 and not necessarily stage 4. This patient had, we said 3 cycles of our R-CHOP.
Completed R-CHOP 3 months ago.
Oh, completed R-CHOP. So probably 6 cycles, 3 months ago. All right. So, well, first of all, I hope you're in remission, and doing well. And so now, the observation part for this type of lymphoma would be almost exactly the same as for any regular type of DLBCL. The only thing that I do different, which is not quite in the guidelines yet, is that I do viral loads on patients with EBV positive DLBCL. So in other words, in addition to all the other things, for the blood work, I typically do CAT scans every 6 months, not every 3. I see the patients every 3 months. I do CAT scans every 6 months for 2 years. the first 24 months are the critical period to do imaging surveillance. But in addition to that, I do viral loads every 3 months, because if the viral load was elevated to begin with, and it goes up again during one of the follow-ups, that generally is associated with relapse. So that's something that I monitor very, very carefully. Yeah.
Thank you very much. We have time for a few more questions here. This next patient is wondering what your personal thoughts are on CAR T-cell therapy.
Oh, that's a huge question. To keep it simple, I would say CAR T-cell therapy is the combination of many things. One is a monumental success in terms of the ingenuity of the scientists and physicians who really developed it. Second, and persistence, because I know that there were many times where a lot of people thought that they were not going to, was never going to happen. Number one. Number two, I think just like anything, any new tool is not perfect, and so it is making a very big difference in certain patients. But is also the impact of the difference, especially now that we have data, it perhaps is not as huge as we thought initially it was going to be. And most patients with DLBCL particularly relapse even after CAR T. And that's where I have experience with. I don't have any experience with ALL in CAR T. And the other one is, it's there are a number of complications associated with CAR T-cell therapy that now we know and understand better. So it's a great tool, it's a great additional tool to have for the management of complicated, difficult lymphomas. So it's extremely welcome. It's great. I think that we will continue to need additional therapies though, because they're not just the permanent solution to the problem. Yeah.
Absolutely. Thank you so much. Another question about Waldenstrom's. I have been on ibrutinib for almost 7 years.
Mhm.
What is your opinion of a drug to use when ibrutinib is no longer effective?
Great question. I guess the first thing I would say is that one, we want to make sure that we know that ibrutinib is not effective, and that seems obvious, but I'm assuming that the patient is on kind of maintenance, right? Continuous ibrutinib therapy. So the only way to know for sure is that if the Waldenstrom starts to, to progress, okay, then the question, okay, now what next? And then that's where perhaps the question about why the progression, some, particularly in CLL, that's very well demonstrated, but also in mantle cell lymphoma is very well demonstrated. I think in Waldenstrom as well, that some people develop resistance to ibrutinib. And there are clear mechanisms of resistance now that they can even be tested for. And there are new types of BTK inhibitors that work even when ibrutinib doesn't work anymore. And one of them is pirtobrutinib in particular, which is approved now for CLL and mantle cell lymphoma. I'm not sure pirtobrutinib is approved in Waldenstrom, to be honest with you. I would have to double check, but that would be a BTK inhibitor that is clearly effective even in the ibrutinib resistant. Now there are other drugs, other than BTK inhibitors that could be used. I mean, you could use a monoclonal antibody. You could use Rituxan. You could use obinutuzumab. You could use a lot of other, different drugs for Waldenstrom if necessary. But if you're focused on a BTK, then pirtobrutinib would be definitely a drug that of interest. Yeah.
Thank you so much, Dr. Porcu. I think that's going to be our last question for today. I want to echo all the gratitude here for all you do for patients, and thank you so much for presenting on our program today. And I also want to thank all of the participants today for asking some wonderful questions and for attending. We hope everyone found the information informative and helpful. Please remember, I know there are a lot of questions left over. If you do have any additional questions, or if you'd like to be connected with someone else who's been impacted by lymphoma or by your type of lymphoma, please reach out to the LRF helpline at any time at 800-500-9976, or you can email them at helpline@lymphoma.org. Just as a reminder, at the conclusion of the program, you'll be prompted to complete a program evaluation. We'd love for you to complete that because we do use the feedback to inform future programs. So they are very helpful in ensuring we deliver useful and meaningful programming to you. But with that, thank you again, Dr. Porcu. It's been a wonderful program.
Thank you, everyone. I really enjoyed it. Everyone has a good evening. Okay, take care.
You too. Take care. Good night, everyone.